Well, good afternoon, everyone. At least it's afternoon here in Ireland and maybe different time in different parts of the world. You're very welcome to this session on bridging the solidarity gap. So first, if I just introduce myself, I'm chairing the session, which I'm delighted to do, and delighted also to be a sponsor for the event today. David Weeklam is my name, and I'm the director of the Global Health Programme in Ireland's Health Service Executive, which is Ireland's health service. And within our programme, we undertake many partnership activities by our health service and our institutions with different countries, mainly in Africa and in Asia. So our partnerships typically involve institutions working in different countries, and how we work between countries is very important. So I think this issue of solidarity is a very good one for us to reflect on as we look back on the last 2 years of the pandemic and think about the future. And we've talked about so far around the themes of equity, quality, workforce. And if you look at those different key aspects of the pandemic response, solidarity is central in those issues. And at the start of the pandemic, Dr. Tedros, Director General of WHO, said, the way forward is solidarity, solidarity at the national level, solidarity at the global level. And what do we mean by solidarity? It's about unity, it's about common interest, it's about mutuality. It's what we mean when we say, as we've often said, is we're all in this together. It's what partnerships are about. And of course, it's important, not just during the pandemic, but for all of our global health challenges. We cannot achieve the Sustainable Development Goals, universal health coverage, global health equity, unless we have solidarity. So how do we reflect on solidarity now, 2 years from the start of the pandemic? Was the response a good expression of solidarity, or was it not? I sometimes look back, as I have done in recent months, on the vaccine rollout, and I wonder, did it feel like we were all in this together? Or did it feel like maybe some were being left behind? So we have 4 great panelists in the session to discuss this important issue, and I put 3 questions to them that they're going to speak to. What is their view of solidarity during the pandemic? What was good, what was not good? Then, second question, how can health partnerships contribute in the face of future global health challenges to achieve greater solidarity and equity in global and national responses? And thirdly, how can institutional health partnerships cooperate within a global alliance to advocate and lead towards greater solidarity? So I'm going to invite each of the panelists to make their remarks in turn, and then we'll continue with discussion for the remaining time. And please, if you have any questions, put them in the Q&A, and hopefully we'll have an opportunity to put them to the panelists. So I'd like to just invite our first presenter, Dr. Thin Thing Lang. And she's a doctor and a Burmese national, and she's worked for 16 years in the NHS in the UK. And Thin returned to Myanmar in 2016 out of a desire to contribute to the development of Myanmar's healthcare. She joined TET as country director in January 2017, and has since been leading the UK health partnerships for Myanmar response to the military coup in February 2021. So I think a very good person to kick off our session today. So can I hand over to you, Thin, to do your presentation? Thank you.
Thank you so much, David, for your kind introduction. Good morning, good afternoon, good evening to you all around the world. I'm very grateful to have an opportunity to participate in this panel discussion, reflecting where we were 2 years ago at the beginning of the pandemic. Millions of people, unfortunately, have left us of COVID. Millions of dollars of investment were spent on emergency response to COVID around the world. On more positive note, we have heard so many times throughout the conference again and again how this pandemic has given the international community an opportunity to be more closely interconnected and to build stronger solidarity than ever before. 2 years ago at a COVID conference, I spoke about how Myanmar-UK Health Alliance played a role in coordinating Myanmar and UK partners and the key thoughts to consider in mobilizing the partnerships to tackle the pandemic. I'm amazed that thoughts then and now are not so dissimilar, so I thought it would be I think you may have got the wrong presentation. So sorry. Maybe we can remove the presentation. So sorry that for the inconvenience. Oh, maybe the other second slide is fine. Yeah. Go to the third slide, please. Yeah. So I'm pleased to share my thoughts then and now, and to see the similarities back in 2022, thinking about building back in the midst of pandemic versus thoughts now, thinking about the recovery. Essentially, the core fact is that we need to be working around the healthcare professionals, supporting and nurturing healthcare professionals. At the very beginning, the existing partnerships and the professionals between UK and Myanmar Health Alliance exchange clinical guidelines and academic experience on acute COVID management. As you all know, Myanmar chronically has very low human resources and public health finance resources. Despite of these resources, the first and second wave of COVID-19 were responded under the democratic government with minimal deaths in the region. People of Myanmar acted in solidarity with the government and non-governmental organizations, local and international partners. COVID vaccines were secured as the first country in Southeast Asia ready to be rolled out just before the coup in February last year. However, all these plans went astray after the unlawful military coup. A collapse of health, education, and public services in the country is observed. Several thousands of deaths were witnessed during the third wave of COVID 19 last year in July. The armed conflicts borne out to defend against the military brutal crackdowns with heightened needs of humanitarian assistance for more than 800,000 internally displaced people. The double burden of conflict and the pandemic is completely unjustifiable, leading to many preventable deaths. The similar pattern is sadly seen in Ukraine and many other parts of the world. Although the rest of the world may be coming out of pandemic, it may be tremendously hard for those people in those areas to even get one vaccine being shot safely. Therefore, we must nurture and encourage, enthuse, inform, and support healthcare individuals and diaspora who are working alongside the healthcare professionals in affected area in the world about the importance of global health, because without these individuals, we cannot implement the vision of building solidarity. We must foster the environment where education and training of global health will be possible and accessible for healthcare volunteers around the world. Secondly, we must ensure that organizations and institutions have system in place, available funding to build partnerships and to implement the partnerships policies and deliverables. And we also have heard repeatedly throughout the conference today how important the technology is for all our partnership work. So we must invest more in technology and improvement of technology and digital services and low and middle income countries to get all these services in those places head to head with the rest of the world. And also, the WHO and UN have shown solidarity in bringing all countries together for vaccine acquisition. But like many of us understand that there are many other places who have not had decent coverage for vaccine and left behind. So although there are wonderful policies of quality healthcare and sustainable development goals are in place, we cannot advance any of those without having peace and stability in any part of the world. We must ensure that better enforcement of internationally agreed policies and commitments are translated into firm actions with tangible outcomes, and we stand strongly against all perpetrators violating UN conventions and make them accountable. Finally, if we go to the next slide, please, I would like to emphasize what Dr. Navina Evans started this morning, that all health is global health, because this is an essential concept to be built into our work to narrow gaps between countries, organizations, and healthcare professional level. Thank you so much.
Thank you very much. That was a very excellent presentation and a very, I think, nice introduction to the session. And you particularly highlighted the challenge of solidarity in a situation where there's conflict and humanitarian crisis. And I think you've addressed in a very practical way, I think some of the very practical things about supporting and solidarity involving health professionals and the diaspora, about funding, digital technologies. So thank you for that. So that leads us on to our next presenter. And I'd like now to introduce Dr. Goran Zangana, who's a medical doctor at NHS Lothian and the Royal Infirmary Edinburgh, with experience in acute medicine, public health, epidemiology, health policy, and health systems in conflict-affected settings. Goran is also an NHS Scotland Global Citizenship Champion and has been exploring barriers to decolonising health programmes, exploring the changes needed to achieve true solidarity and equity in health partnership work. So I think that's very apt for our session today. So I'll hand over to you, Goran. So please go ahead.
So much, David. Can you hear me well?
Yes, indeed.
Perfect. Thank you so much for that generous introduction, and congratulations. You are one of the few people who pronounce my name correctly, Zangana. So yeah, I'm very honored and privileged to be here, and thank you so much for the amazing job they are doing organizing this conference and the excellent speakers who preceded us, and I'm sure they will follow. So my talk is about trying to address some of the questions that David posed about solidarity and about the future. And what I'm going to talk about is some observations that we made about some of the NHS or wider global citizenship and public health and global health partnerships. So the things that I'm talking about is not specific to the NHS. It hopefully applies to a number of global health partnerships around the world. And I'm going to try to use the what we call the global health decolonizing literature, as well as the path dependency literature and some literature related to policy transfer or policy translation. So the first observation that we make about global health partnerships around the world is there is a legacy, there is a history that unfortunately it's kind of replicating itself and perpetuating itself. And one aspect of that history is the connection between medicine and colonialism and how medicine was used as a colonial tool for imperial expansion. Medicine used as a justification for colonial expansion. Unfortunately, we see in some aspects of global health at the moment, currently, a replication of that heritage and history. The other aspect of global health partnerships that are also kind of highlighted by the decolonizing global health literature is the superiority of medicine, is the superiority of the biomedical model in global health partnerships. Most of the time, we see that skills and techniques that are kind of super specialized and mostly surgical or also medical are transferred, kind of unidirectionally transferred from the global north to the global south. So this is that kind of critique of the dominance of the biomedical model and specialized medicine in global health partnerships. The third critique, I think, and all of these are constructive criticism, I hope, and we'll try to address some of those questions that David posed. The third critique is the limited participation and engagement with global south colleagues, individuals, and institutions and organizations. If you look at global health initiatives and partnerships and organizations, they are dominated by individuals, colleagues, and organizations and institutions in the global north. As other speakers talked about technology nowadays can provide a big opportunity that I'm going to talk about a little bit in my recommendations. So to conclude, there are three main areas that we can address in trying to kind of answer some of the questions that David posed. The first one is to be aware of the heritage of the history of how global health developed and what path it took from decisions and actions that were taken in the past related to colonialism and imperial expansion. That's number one. Number two is probably a shift from the exclusive domination of biomedical and specialized clinical skills to more a primary healthcare approach, to a public health approach in global health partnerships. And finally, and again, this can be helped by the use of technology that actually the pandemic provided, is to try to engage and more include and involve colleagues and individuals and institutions and organizations from the global south, not only to talk to them but also to listen to them and share lessons and learn from those lessons and engage in true a mutual partnership and coordination and participation and inclusion. So with that, I'd like to conclude my remarks, and thank you so much again for that, and thank you so much again, David, for moderating this excellent session.
Thank you very much, Goran. That was very insightful, and I hope maybe we might get a chance to come back and explore those issues more. And I think it's good, the reminder of our history, learning from our history and the way we've maybe done things in the past and how we can use that to build a better future. So thank you for that. So we'd like to move on then to our next speaker, who's Professor Francis Omaswa. And I've had the privilege of working with Francis over a good number of years, and Francis is a great champion and leader for health in Africa and globally. And currently, Francis is the executive director of ACHEST, a think tank based in Kampala, Uganda, that focuses on health system leadership and governance, health workforce and strategic communication. In the past, he served as the founding executive director of the Global Health Workforce Alliance, and he was previously also Director General of the Health Services in the Ministry of Health in Uganda. So I think Francis is very well placed to speak on this topic. Francis, I look forward to hearing your remarks.
Hi, David. So nice to see you. You are looking good. And I have other friends in the panel. Amanda, a long time. COVID has separated us. And I have friends in Myanmar as well. And of course, our colleague from Edinburgh. I'm a fellow of the Royal College of Surgeons of Edinburgh. I took exams at the Royal Infirmary, so I'm connected with all my colleagues here. Okay, let's go to the topic which has brought us here together. Solidarity. What is solidarity? What is it all about? What are the foundations of solidarity? I would like to propose that we look at this as a very, very important human issue. Solidarity is about our humanity. In each of us, there is in our genes a sense of feeling for each other. You see an accident in the street, you look through your window, you don't know who it is, you don't celebrate it, you say sorry. And it is this feeling for each other that has made it possible for humans to get together, accumulate the knowledge that they have, and use it for improving the world as far as it has gone today. On the other hand, there is the other trait also of greed, ownership. This is mine, go away. And we were told in a meeting I attended 3 years ago in Berlin that the economics which has been taught for the last 40 years of profit, greed, was a mistake. And we now have that tension between those who tend to work for themselves and those who tend to work for the common good. But I am sure that at the end of the day, the common good tendency is going to prevail, and we should work for it. And it's the reason why we are here today, promoting the common good, promoting those who care for each other, and each of us, wherever we are, as individuals in our institutions, having that at the back of our minds. We are working for the common good. We are working for the common good. Now, as of COVID now, I was privileged to work as the chair of the National Committee on Community Engagement for COVID. And tremendous lessons. We set up village COVID committees in all the villages in Uganda. And the performance of these committees was varied. Those which were better led were very impressive to watch how together they solved their problems, identified their problems, solved them themselves, and it helped working with the village health teams, community health workers. Those communities were on top of their COVID as opposed to those who were not. Now, if you come to national level, this solidarity is about stronger health systems. Health systems are made of different parts in each country, the Ministry of Health, the other line ministries, civil society, academia, and so on. And if this can work together, then we are talking about promoting solidarity. So strong health systems at national level is the future. And then as an African, I know that if you have a strong health system in a country, then it's better able to negotiate with the global forces. And my tendency now is more and more to say, when the conversation on decolonization of health comes up, that it is our fault. We have allowed it to happen, we people from the South. And if we can mobilize ourselves, we should be able to get together and make sure that no one comes home to our countries just to play around. So I would like, as conclude my submission now, essentially to say that solidarity is embedded in our humanity. Let's promote it wherever we are. Let's build strong community health systems, strong national health systems, and then based on strong national health systems, we are able to engage at the global level more effectively. We've seen the vaccine nationalism over COVID, and the response from Africa now is a wake up, wake up, wake up. This is a threat to your own survival, and transfer of technology is the next move. And this again is asking for solidarity for those who care. And they are there, plenty of them around the world. Let's tap them, use them to create a better world. Thank you.
Thank you very much, Francis. And as usual, you also have some very special things to share. And I really liked how you really brought it down to the national level. I mean, we're looking today at both solidarity at a global level and at a country national level. And I think you've reminded us of the importance of seeing it starting in the national level with the way we work together, and the whole idea of we work together around a health system. And then that leads us into solidarity at the international level. So thanks for sharing that. So now we'll have our fourth presenter. I'd like to introduce Amanda Banda, who works at WAMOS and is a global health advocate in the East and Southern African region. And Amanda focuses on the programs Human Resources for Health and Finances for Health. She's also co-chair of the Health Workers for All Coalition. Amanda has over 13 years of experience influencing many national governments in Africa, global health institutes and donors, holding them accountable and calling to prioritize investments in health. So I think another person with a very good perspective to bring on the issue of solidarity. So over to you, Amanda.
Unfortunately, David. Oh, I think it's rejoined.
Can you hear me?
Yes, we can hear you.
Oh, great. Thank you so much. And unfortunately, yes, I had a minor technology glitch there. I disconnected, but I'm glad to be back. Thank you so much, David, for the introduction, and also really great to hear very strong insights from other panelists and speakers. And I think I would like to build up on what the previous speakers have said, really touching on the solidarity aspect, and maybe just touching on what Francis presented. I think that we've seen it's the concept of solidarity for me has been a bit of a, I mean, the challenge is the struggle with the concept on the more broader political level to the issues that Francis has highlighted on the, vaccine nationalism, but also, tech transfer, which is still a challenge that many of us here on the panel, but also those that are watching and listening, still, tackling and trying to to bring and to push in a way, but at the same time, so there's that broader bigger political challenges in terms of solidarity. But I think the beauty that we've seen with COVID is also that organizations and our partnerships like ourselves and a lot others out there really have worked together to fight COVID, but also really to put the interest of the populations at the center vis-a-vis, of course, interest of the market. And I liked what Dr. Zangana alluded to. I think it really stuck, medicine being used as a tool for colonial expansion. And I think really also like the response or addition from Dr. Professor Mansour on, are we perhaps allowing it, and the thoughts around, centering approaches, to primary health care and public approach. And I would just like to acknowledge and agree all those points, I think, which really have struck me for today. But I just want to focus as well and just bring a few thoughts in addition to this. I think that looking at health workers, for example, and maybe in specific, I think I think for me, that's one area that we haven't seen as much solidarity. I think we've seen a lot of applause, yes, and a lot of clapping of hands earlier at the onset of the pandemic. And what we've seen as more of a response in terms of solidarity actually is the provision of PPE to healthcare workers, but vaccine delivery to healthcare workers also has not been as great or as equal and as faster as we would have imagined. And I think that this was the population also quite left behind, the deaths of healthcare workers amidst the shortages. I think that WHO estimates plus or minus 180,000 healthcare workers dying from the pandemic itself. And we don't yet have estimated figures at this moment in terms of, other attrition, those who have left the profession altogether. But there is also a lot of health worker professionals that have actually migrated in search of greener pastures. We're looking at information and data from Zimbabwe that was showing within a period of 1 year, over 2,000 healthcare workers in the midst of the COVID pandemic have migrated, and no any sign of solidarity and conversations around what are we doing. Yes, they have the right to migrate, but what conversations are governments having with one another in terms of how to increase investments for the source countries to ensure that they themselves are not impacted, because you're looking at these are countries that have the most severe shortages of healthcare workers. And so what are we doing about it? I think for me, this is where it's still a bit not so strong in terms of how we are responding and reacting when it comes to bringing solidarity in the response to the pandemic. And I also just want to agree on the health systems aspect. I think this is key and still very much underfunded. I think at least we've seen an increased acknowledgement that health systems is key and it's very important, but there is not enough action, following the recognition that this is really key. And even in the conversations now going on around, future pandemic response and preparedness, health systems, health workforce, even though being acknowledged. I mean, if you're going to have to take, service delivery right down to the primary healthcare level, I think there's strong need for the systems and the health workforce investments. And these are not the current priorities and features in the conversations that are even going on around the, prevention and preparedness of, for future pandemics. And so I think that for me, it's still something that I'm worried about, despite everything else that we have seen really coming strongly together when it comes to, solidarity and responses. But I think that these issues actually maybe are the fundamental issues, because I mean, when you look at the nationalism aspect, which for me links to the decolonization of global health and technology transfers, these have always been the sticky issues, in global health and health systems and health workforce. They're always the sticky issues in global health. And COVID should at least would have given us, I would have imagined, would have given us the opportunity to react differently. But it's again showing that we're falling in the same traps. And I think those very same issues where we would have expected more solidarity to the point on humanity that Professor mentioned, we still stuck. And so we still have a long way to go. And of course, it's not lost. I think there's a lot of, like I said, maybe on the broader political level, these issues remain stuck. But the beauty of it is that organizations like ourselves, there's a lot of work going on a very small scale, and maybe to a large extent as well, really trying to push and unpack and really unblock, these blockages of solidarity. And I think that would be my last point in terms of then what will it take if it's not COVID, to move past these barriers of what we have seen as consistent, red flags and issues in global health that do hinder solidarity. Thank you so much.
Well, thank you very much, Amanda. And I think you've picked up very nicely on some of the things brought up by some of the other speakers. And you've certainly spoken to very strongly about the importance of looking after health workers in the partnerships. I've been looking at the Q&A and I don't see so much in as yet. If you have any questions, maybe now's a good time to put them in that maybe we can come back to the presenters with. But in the meantime, I'd like to come back to each of you and perhaps with a different question for each of you. And based on your remarks, thinking of what are some of the lessons that we can take away, those of us who are involved in institutional health partnerships, what can we learn from your different perspectives? And maybe if I could come back to you first, Tin, and the very challenging context you described in Myanmar. And it's just struck me here in your partnership with the UK is a very long distance away. Mm-hmm. And we now in the Ukrainian crisis, which you also referred to, have seen a lot of solidarity across Europe because geographically we're very close to each other. And the question maybe to put to you is, how do we achieve that solidarity between countries when there is that very long distance? And what has been your experience about that, and how can that solidarity been maintained across continents when the distance is so far away?
Thank you, David. Yes, from our experience over the last year, as we all agree that technology and the availability of internet has changed how we all engage and connected, and the experience of providing virtual training has actually delivered and changed our vision. Prior to the COVID, there was there are a proportion of people in Myanmar who did not actually use Zoom or any other communication software. Now up to speed with all these communications, and this has become part of our lives. So this is one positive thing that we have to learn. We can do things differently. It is not the it is not the distance nor the physical presence, but it's all matters to the willingness and the commitment and the common goal that we both partnerships agree to work into. These are the common principles of partnerships that underpin how we want to do things differently. So this is one learning point. And second of all, what interests me is the solidarity of the European countries around Ukraine and the support for Ukraine. This has intrigued me really, because if you are following the politics in ASEAN and the Asian countries, the solidarity and the support for Burma is really divisive, especially between the ASEAN country, which is sad. If you know, countries like China or India are more supportive and cooperative of what people of Myanmar wanted, then I think the people of Myanmar would not have suffered this long enough. So I don't think, in essence, the distance matters. It's the country, it's the commitment and the common goal and the common value to our human rights and democracy, and the understanding of, you know, the world as a one common village and the one place is the answer to all. Thank you.
Thank you very much, Then that's very interesting. Maybe to move on, the question for you, Goran, and for following your remarks, and you looking at our history and the focus on medicalization of healthcare. And it struck me when thinking about a lot of our institutional partnerships, they often involve hospitals, because hospitals are large institutions and they can link, our large institutions can link with each other. But primary care is organized differently, and it's maybe less easy to develop partnerships between primary care institutions. And just wondering, have you any thoughts on that? And practically, for those of us involved with partnerships, how can we bring that greater focus in our partnership work to primary healthcare and community-based healthcare?
Absolutely. I think a couple of ways, and I agree with Amanda, with Professor Francis, about how we can harness the technological resources, and hopefully COVID and the Black Lives Matter was kind of a wake-up call, a crisis that we can use as an opportunity to address some of the questions you did. And the shift to primary healthcare, I think it starts from the global north. As I said in my remarks, most of the partnerships that start from the global north are by physicians, by specialists, by surgeons. We need to involve other colleagues from primary healthcare, from GP surgeries, from public health specialists, experts, etc. And then, as other colleagues mentioned, we can use technology. We can use Zoom, the power of platforms like this one, to engage colleagues on the ground, like the ones that Professor Francis mentioned, the committees, the village committees on the ground, and to learn from them. And also, I'm sure in Myanmar and in other countries, in my native country of Iraq, there have been community health workers. There have been people like the video that was shown before our session, women that are engaged in their own healthcare. So things like that, we can engage with things like that and learn from and exchange lessons. So again, it's a two-way partnership. It's not one way. We should move away from the one-way exchange that has been happening so far and make it more interactive, exchangeable, and organic. I would argue.
Yes, thanks very much, Karen. That's very, very helpful response. If I could move on to you, Francis, and just I liked how you got us to think about health systems and how health systems are made up of us all working together, different parts working together. And I'm wondering what you would say about those of us who work in partnerships that often involve maybe just one institution linking with another, that there can be sometimes very good work done at a local level. How can that work at a local level feed into strengthening the wider health system? How can our health partnerships make a greater contribution to national health systems?
Francis. Apologies, you're on mute.
Did you hear my question, Francis?
I heard your question, but I'm speaking to myself, muted. Sorry. Sorry about that. I was thanking you for the very relevant question, because it starts with local, as I said before, and it is because of strong and active local institutions that we are able to engage with partners at the global level or regional level, like East Africa or Africa. So let me give you an example of something which has worked, which I think you've been part of, David. This very set who has convened us today, they established the Uganda-UK Health Alliance with the partnership here, and then they invited our organization to address the question of the attitude of the UK government on implementation of the WHO code on the international recruitment of health personnel. Amanda rightly pointed out the issue of a huge exodus of health workers from Zimbabwe to the UK mainly. So what did we do? We convened a meeting with the UK government leadership, because their recruitment agencies were advertising openly here in Africa. We also wrote a letter from the government of Uganda, a letter drafted by an NGO, to the WHO Director General to say UK recruitment agencies are doing this in Africa. And WHO drew this to the attention of the UK government. Together with the 13th intervention, the policy of the UK government towards international recruitment of health workers as we speak today is different. They are using the code more. And that is again about what I said before: strong local organizations, strong health systems in countries, strong leadership in countries, strong health leadership in countries, impacting global. So I would like to continue to advocate strongly that we support stronger health systems in the country, supporting the government, supporting the CSOs, and then together in each country, there should be ability to organize internally and to negotiate globally. And I think that way, our humanity and solidarity is likely to achieve the goals which we wish for. Thank you.
Thank you very much, Francis. I'm going to just our time. We just need to finish up shortly, and I'd like to give Amanda just a chance also to respond for the last question, and just really maybe to pick up, Amanda, on that issue of the health workforce, which you also spoke about. And in our health partnerships, it is about health professionals working together across the partnership and working on sometimes very good projects. But I think from your remarks, it sounds like maybe during COVID, not enough attention was paid to the health workers themselves. And maybe just by a last comment, could you suggest how can we do better in this way in our partnerships to support the health professionals that we're working with?
Thank you so much, Dr. Wickley. So I think that it's the continuation of putting the needs. I think like we always talking about, primary healthcare. We always talking about, people-centered care, but really not really thinking about the individuals as well. Because when it comes to health delivery, we're looking at trying to shift the focus from the systems lens to the individual receiving care and their needs and how they live their lives, but barely we focus on the persons themselves delivering that care, which is critical. And I think for me, one practical point would be to begin to engage the health professionals and the healthcare workers themselves in a lot of the decision-making spaces that are taking place, because often they're also except when it comes to, you know, clinical guidelines and development of such policies and decisions, of course, yes, but on a broader sense, on resourcing decisions, oftentimes in a lot of governments, they're not on the table, they're not really represented and speaking to the issues, and not just the clinical healthcare cadres, but also the community ones as well. So bringing them into the conversations, I think, will really bring rounded conversations that also have, you know, comprehensive solutions, not just from the perspective of the persons receiving care, and that's very important. We need to really emphasize, and they cannot emphasize that enough, that it works, you know, people-centered care works, but how are we integrating and bringing in the aspect of the persons delivering that care themselves? And I think just being intentional in paying closer needs or paying closer attention to the needs of the health workforce, I think would be a very good start. Thank you.
Thank you very much, Amanda. Yes, so we've had some, thank you for so much to all of the panelists. I think we've had some great inputs from you. I think it's been a very interesting session. So the time is up, so we do need to draw to a close. So I'd just like to end with that, with thanking all of you for your participation and contributions. And we'll finish up there, and I think the next session is due to start. Thank you.